Hello everyone, today we'll discuss about surgical energy devices and electrosurgery. Electrosurgery employs high frequency alternating current to assist in making surgical incisions, tissue dissection and achieve hemostasis. Its widespread use spans open, laparoscopic and intraluminal endoscopic surgeries. More than 5% of all laparoscopic complications are electrosurgical injuries. Unseen strain energy accounts for severe disability, death, and significant litigation. In 2010, tragic death of Congressman John Murtha due to unrecognized electrosurgical injury during a laparoscopic cholecystectomy led to the development of FUSE by SAGES. SAGES is the Society of American Gastrointestinal and Endoscopic Surgeons. FUSE is the fundamental use of surgical energy. The curriculum to combat the widespread lack of in-depth physical knowledge among surgeons. Energy devices can be classified into radiofrequency, ultrasonic, laser, plasma energy, and ablative devices. In radiofrequency, we have monopolar, bipolar fusion, saline cooled radiofrequency dissectors. In ultrasonics, we have harmonics, QSA, and the shock waves. In laser, we have the NDAC, CO2, KTP, photodynamic therapy, and shock waves. Plasma energy, we have the ABC, argon beam coagulator, and in ablation, we have radio frequency ablation and microwave ablation. The most common energy source is the radio frequency energy. 50 to 60 Hz is the household AC current, which is the wall outlet current and is a standard power. In less than 10,000 Hz, when it passes through the human body, it stimulates the nerves and muscles, which is dangerous for surgery as it causes tetany and electrocution. And when the power is 5 lakh to 30 lakh Hz, it is suitable for surgery. The current passes through the tissues purely as thermal energy without neuromuscular stimulation. As it passes through the tissue so rapidly, the cells convert the kinetic energy directly into heat and completely the neuromuscular stimulation is bypassed. So, the use of more than 10,000 Hz is mandatory to avoid neuromuscular stimulation. The most common energy source, that is the radiofrequency electrosurgery, using an alternating current with a frequency of 5 lakh cycles per second. Tissue heating progress through the well-known phases. The first is the coagulation phase, and the temperature is around 60 degrees centigrade. The cellular proteins uncoiling and webbing together, blanching effect. Cells are intact but proteins denature. When the tissue temperature reaches to 100 degrees centigrade, vaporization and desiccation occurs. Water inside the cell boils leads to tissue division, cutting. And when the temperature is more than 200 degrees centigrade, carbonization occurs. There is complete destruction. The two common methods of delivering radiofrequency electrosurgery are with monopolar and bipolar electrodes. The circuit is generator, tip, patient, and the pad. The voltage requirement is high, 1400 to 9000 volts to push through the whole body. The dispensive pad is mandatory. Drawbacks are higher risk of stray energy and capacitive blocking. In bipolar, the circuit is the generator, jaw 1, intervening tissue, and the jaw 2. Voltage requirement is low, it is 100 to 200 volts. Dispersive pad is unnecessary. Benefits extremely contained, thermal spread, safe for patient with implants. The differences between the monopolar and bipolar. It is a single electrode. The diathermy pencil is used. In bipolar, there are two active electrodes, forceps or scissor limbs are used. In the return path, it returns via large dispersive plate on patient's body. There is no dispersive electrode needed. The voltage is 1400 to 9000 volts. In bipolar, it is 100 to 200 volts. Smaller tissue contact, lower voltage needed. The current path, it travels through the entire body. It passes only through the instrument tips in bipolar. Thermal spread, it has extensive lateral spread for the monopolar and minimal lateral spread for bipolar. The pros: monopolar is inexpensive, versatile, easy to modulate. The bipolar, it is precise, safe near vital structures, safe with implants. Feature: hazards: burns, capacitive coupling, channeling, antenna coupling for monopolar, and for bipolar, they cannot cut basic slight increased operative time with advanced bipolar. The uses: the monopolar in open, laparoscopic, endoluminal, and robotic surgery. Bipolar near recurrent laryngeal nerves in thyroidectomy, patients with pacemakers or ICDs. The monopolar electrosurgery modes, the cutting versus the coagulation modes. The cutting, there is continuous passage of the current and the voltage is lower. The effect on the tissue, the energy is concentrated over a smaller area. Tissue heats rapidly, causing vaporization. This divides the tissue by generating sparks just above the surface. There is minimum lateral spread, that is around less than 200 micrometers. In coagulation, there is interrupted flow of the current, 6% off and 94% off. The voltage is higher. The tissue effect, the modulated current allows tissue to cool slightly. The tissue dehydrates rather than vaporizes, and there is protein denaturation. There is extensive lateral spread. It causes vessel thrombosis. The blend mode replaces pure cutting with small periods of inactivity to achieve partial coagulative effects. So the other forms of the monopolar radiofrequency energy source, the cut and cog we have already discussed. The others are the fulguration or the spray mode, and the last one is the blend mode. Discussing all the modes together, cutting is continuous, low frequency voltage current of 1400 to 9000 volts. There is rapid heating causing vaporization, less lateral thermal injury spread, and the lateral spread is minimal. In coagulation, there is interrupted. It is high voltage. There is slow heating, 60 to 95 degrees, and protein denaturation plus desiccation. No vaporization occurs here. It is extensive lateral spread. Fulguration is the coagulation mode. No contact higher. There is arc to the tissue, more than 200 degrees centigrade. There is eschar or carbonization. The penetration is less than 5 mm. The lateral spread is moderate. The blend mode, mixed continuous plus interruption flow of current is there. The voltage used is intermediate. It is partial cut plus coagulation. The lateral spread is intermediate. The image shows monopolar energy effect on the tissues. The first is the cutting, the second is the blended, the third is the coag, and the fourth is the spray mode. Cut mode is more effective than coagulation mode for vessel sealing. The continuous cut waveform evenly heats tissue between forceps, producing a homogeneous seal. Desiccation. The coagulation mode with contact should not be used for vessel sealing. The advanced bipolar are the ligashore and the end shell. They are useful in closure of the vessels of up to 7 mm size. The sealing time is 2 to 4 seconds. There is compression. The mechanical jaws are applied uniformly and uniform pressure squeezing out blood and fluids is produced. Then the energy is given. The bipolar radio frequency energy transfers with real-time tissue impedance monitoring to optimize seal. Then denaturation. The collagen and elastin are cross-linked to form the permanent seal, and a mechanical blade is used to divide the tissues. The advanced vessel sealing. The bipolar methods are the ligashore and saline cooled frequency aquaminus, and ultrasonic measures, the harmonic scalpel, and ultrasonic with the bipolar, the thunderbeat are also the modes. In bipolar, ligashore and seal we have already discussed. In saline cooled aquamins, there is steady saline irrigation to contact point, then the surface temperature is less than 105. It prevents escarp formation. In the harmonics, there is the ultrasonic energy that causes the protein denaturation. The vessel size is up to 3 mm. There is no electric energy to the patient and is safe with implants. The Thunderbeat, it uses both the ultrasonic and the bipolar diathermy in a single device. It is the fastest sealing method. The saline cooled radio frequency desiccators, they solve the problem of the HCAR. There is stranded radio frequency which heats surface too fast, creating dense HCAR that blocks deeper coagulation. Saline irrigation maintains the surface temperature of less than 105. The result is deep, constant coagulation of solid organ parenchyma without surface charring. Ultrasonics, it produces the egg white effect, that is the vibrations of 44,000 Hz causes friction and protein denaturation, which is like whisking of the egg white. The harmonic scalpel, the metallic jaw, the mechanical vibration of active plate against the static plate, it causes the vaporization and coagulation. The high energy causes the rapid cutting, the low energy produces coagulation. There is no cutting bleeded needed. The vibration divides the tissues. The byproduct creates a transitional cavitational mist rather than dense smoke, improving operational visibility. It works at low temperature. It cuts down below the boiling point, that is less than 100 degrees, and minimizes the charring. In CUSA, the Cavitron ultrasonic surgical aspirator, the hollow titanium tip vibrates longitudinally and fragments the parenchyma. The low water content endothelium and bile ducts of the vessels, they are all spared, while the high water content hepatocytes are exploded. This provides a precise resection plane without vessel sealing capability. The advantage is that as it works on ultrasound energy, there is no capacitive coupling, no channeling, no direct coupling, and the minimal EMI. But before touching the tissue, we should wait for 5 seconds for the activation before touching, as the residual heat produced is more than 200 degrees centigrade. The plasma energy, that is the ABC, organ beam coagulator. The dryer, the gas physically causes pooling of the blood, providing a dry field. Radio frequency current travels down the high conductive organ gas stream. The seal, it achieved rapid, uniform, shallow coagulation across a wide surface area. The mechanism, the focused organ gas, a high conductive inert gas, carries short 40 microseconds bursts of radio frequency energy to the tissue, distributing electrons evenly over the surface. This is an adequate adoption for monopolar energy and not a laser. It provides constant 2 to 3 mm superficial thermal spread. It is ideal for coagulating diffusely bleeding surfaces. Example, the cut liver edge spleen in a field filled with blood or debris. It produces minimal smoke compared to standard electrosurgery. The severe warning is that intravascular embolism of insoluble organ gas can lead to cardiac arrest and death. Avoid direct tissue contact and minimum gas flow volume. In laparoscopy, it must vent ports, monitor insufflation pressure closely. The danger is that organ gas embolism can cause cardiac arrest and death. In laparoscopy, it is mandatory that the vent ports and the monitor insufflation pressure is monitored. Avoid tissue contact and minimize gas flow volume. It has the highest EMIs of all devices. It is avoided in pacemaker patients. Ablative forms of the energy, the radio frequency and the microwave ablations. The radio frequency ablation, it uses high frequency alternating current and it needs a grounding pad. The vulnerability or the advantage, the heat sink effect. The thermal energy is rapidly dispersed by flowing blood in nearby vessels, creating a cold spot and limiting efficacy. Limits and safety. Best for tumors up to 3 mm. Contraindications are the implantable electronic devices or the metallic clips. Constraints are the grounding pad is required. and is strictly contraindicated in patients with metallic implants. In the microwave ablation, electromagnetic waves oscillate polar molecule, that is water, generating frictional heat. There is no pad required. Advantage is that attenuated heat causes sink effect, creates larger, faster, and more homogeneous zone of necrosis. Safe to use near metallic clips and implants. The advantages are that there is no grounding point needed, and it is safe to use near metallic clips and has no electric circuit to be created. The surgical lasers, carbon dioxide, KTP, and Nd:YAG are the different forms of lasers. Carbon dioxide, it has superficial ablation and cutting. It is delivered via mirrors, ideal for unreachable sites like vocal cord granulomas. Deep heating can cause hollow viscous perforation. KTP, the frequency doubled Nd:YAG laser, also known as the KTP laser, potassium thionyl phosphate crystal, the chromophore selective and absorbed highly by red pigments, that is hemoglobin, ideal for coagulation, flat vascular lesions like cecum, and safely used without perforation risk. The Nd:YAG, it is 1064 nanometers, represents the nadir or oxyhemoglobin and melanin absorption, allowing the deepest possible tissue destruction, used for large fungating GI tumors. And the fourth is the pulse dye lasers, which utilize variable wavelengths with extreme rapid discharge to create physical shock waves which can fragment kidney and gallstones. Photodynamic therapy, it is a unique application of laser technology. It provides extremely rapid discharge, less than 10 seconds, of large amounts of energy. Palliative treatment for obstructive cancers of GIT. An IV dose of Porphymer sodium is administered, which acts as photosensitizing agent that is taken up by malignant cells. 2 days after the administration, the drug is endoscopically activated using a laser. The activated Porphymer sodium generates oxygen-free radicals which kills the tumor cells. The tumor is later endoscopically debrided. The use of this modality of definitive treatment of early cancers is limited. The hazards or the electrosurgical injuries, environmental and thermodynamic errors are the OR fire triangle and the residual heat, the invisible physics of stray energy, the antenna coupling and the capacitive coupling, conductive intrusions and defects, insulation failure and direct coupling, mishandling and system interference, direct application, electromagnetic interference. The operating room fires, there is a fire triangle, there is the ignition source, that is a surgeon, through the electrosurgical units, lasers, fiber optic light colors, the anesthesiologist, the oxidizer, is supplemented oxygen in the airway or the tented under drapes. The fuel is a nurse. Alcohol based preparation must be dried completely and there should be no drip pulling and the proper surgical drape should be used. Action plan, the rescue, attempt to rescue the patient or the staff, alert, activate the fire alarm and alert nearby staff, confine, isolate the fire by closing doors, shutting off medical gas and electrical power, evacuate, evacuate the incident room and the entire surgical suite if necessary, immediate steps for airway fire, stop airway gases, disconnect breathing circuit, remove ET tube. Antenna coupling, the antenna effect, the radio frequency energy transmits through air into nearby conductors like can antenna picking up a radio station. So the monopolar cable, the active electrode, it passes radio frequency energy to the nearby camera cord. So bundling the camera light and Bowie cords together during a lab colic can cause the camera scope to arc energy into the bowel. So this is prevented by separating the active electrode cords from all other wires of the surgical field. The insulation failure, the mechanism. High voltage energy arcs from a microscopic crack in the instrument's protective casing directly to adjacent structures outside the surgeon's field of view. Laparoscopic L hook damaged and the current passing to the adjacent structures like bowel or the liver. Only 10% of insulation defects are visible to the naked eye. How can it be prevented? Requires routine porosity detection during the sterile processing of reusable instruments. Careful pre-use inspection for obvious break. Maximum visualization of instrument during activation. Routine electrical testing. Porosity detection of all reusable devices like L hooks, spatulas, graspers, and scissors. The residual heat, it's all been already we discussed in the ultrasonics. There is unlike electrical devices that cool almost instantly when current stops, ultrasonic friction creates residual physical heat. Ultrasonic devices commonly hit maximum temperature of more than 200 degrees centigrade. So transecting the tissue and then immediately using the hot inactive tip to grasp retract small bowel results in full thickness thermal injury and delayed perforation. The protocol to be followed: 5-second rule, mandatory 5-second waiting period post activation before using the tip for tissue manipulation should be followed.
Direct coupling injuries, they happen by direct application or through the direct coupling. Unintentionally activation while the tip contacts tissue. This happens on leaning forward onto the foot pedal and accounts to 85% of reported injuries. The direct coupling, the active electrode touches another metal instrument like a suction irrigation or a grasper, turning the entire secondary instrument into a branding iron. In capacitive coupling, the active electrode creates a strong electromagnetic field and the energy transfers across the intact insulation to the metal cannula. The plastic collar insulates the cannula from the abdominal wall, preventing safe dispersal of stray current. The highly charged metal cannulas arcs directly into large bowel, causing unrecognized thermal necrosis and delayed fecal fistula. So, a plastic collar and plastic trocars are safe for usage. Cardiac devices and the vector of danger. Insect, intersecting the pacemaker vector causes severe electromagnetic interference leading to inappropriate shocks or pacing failure. Total spatial separation and place a grounding pad so the current vector avoids the thorax entirely. The device of choice: utilize low energy devices, bipolar or ultrasonic, with an electromagnetic interference profile of approximately 0.01 millivolts compared to monopolars with approximately 0.92 millivolts. The surgical smoke produced during electrocautery, viral particles, bacteria, and carcinogens are bioaerolized in diathermy smoke. So, the protocol: mandatory use of universal precautions and smoke extraction systems needs to be followed. The checklist for safety. So, the circuit check: are we using bipolar whenever possible? Is a monopolar pad safely vectored away from implants? In device check: has the insulation of reusable instruments been porosity tested? In environment check: is the environment alcohol preparation dry? Is oxygen less than 30% when working near the airway? Execution check: are cords separated on the drape? Are we honoring the 5-second ultrasonic cooling rule? Mastery of surgical energy is not just knowing how to cut, it is controlling the invisible circuit to prevent spark before it arcs. So the controls need to be taken care. PPE, personal protection equipment, it protects the workers themselves, and the administrative controls change the way people work, educate them, and mitigate techniques. The engineering control isolate people from hazard, ensure only the necessary people are in the OR. Substitution replace the hazard, utilize positive negative pressure rooms. Elimination physically remove the hazard, ensure OR ventilation more than 15 exchange per hour. Electromagnetic interference. The safe ones are the advanced bipolar, traditional bipolar, and the ultrasonic shears. Caution needs to be watched while using monopolars with a strength of 0.21 to 0.92, as they can cause defibrillizing sensation and shocks. In high risk are the organ plasma and the plasma energies, which have more than 2.58 millivolts of energy and can cause damage. And for patients with pacemakers and intracardiac defibrillators, strictly bipolar or ultrasonic device should be used, and alignment should be avoided with the implantable device current vector to prevent fatal malfunction. A clinical scenario and the device activations. For patients with implanted cardiac pacemaker or ICD, select advanced bipolar or ultrasonic, strictly avoid monopolar or organ. For goal to secure a seal of 7 mm vessel quickly, select advanced bipolar ligashore or combination device. Thunderbeat, avoid contact coagulation mode. In dissecting a diffuse bleeding highly vascular solid organ bed like liver, select CUSA to spare bile ducts, or organ beam coagulator for superficial coagulation of large flat surface. For surgeries requiring single incision with forced parallel instrument alignment, select bipolar or ultrasonic. Avoid monopolar to eliminate antenna and capacitive coupling risks. Mastery of continuous alignment to the target tissue, the local physics and hardware inherent limitations.